Hi, Dr. Beth. How are you doing today?
Oh, I'm good. How are you doing today?
Oh, I'm okay.
Had a long day.
Yeah.
Today.
Stressful. I know. When you're on floss, you can get busy.
Yeah.
Well, we still need to make some short video for our listeners. So let me use the opportunity to welcome our listeners and viewers. In today's episode, we'll discuss a very short but important subject, and that is an effective sign-off.
Why is it so important to you?
Well, you don't want to be on a night medicine and the nurses will be paging you about patients you have no idea about, right?
Of course, that would be annoying, especially when you are
admitting 5 to 10 patients and you have to be responding to those pages about patients that hasn't been signed out to you. It's not something you enjoy. So let's teach our audience how to, sign off or sign out effectively. Yeah. So do you have any clinical scenario that you want to use to demonstrate how an effective sign out should go? Then I will break it down as to what components of framework it entails.
Yeah, sure. So I'm the 72-year-old Mr. Jones in room 312. He's a full code and a watcher. He is here for an upper GI bleed in the 13th of Medina. His presenting age was 6.8. He's been transfused with 2 units of RBCs. So the sign out is for, I'm training this H&H every 8 hours. Sign out is for H&H. So should his hemoglobin be less than 8, given that he has a history of coronary artery disease, at 6 p.m., hemotransfuse 1 unit of pancreatic red cells, or if he's hemodynamic and stable. And if he's still bleeding, you can get a CTA and then call GI. GI is aware.
Okay, all right. So Dr. Beko just demonstrated how, sign out is done, and I'm going to break down the components of sign out to our viewers so that they have an idea of how to sign off effectively their patients to the on-call team when they start their residency. So the framework or the mnemonic that is used is the IPASS mnemonic. The I stands for illness severity, but I've added my own twist to it, which is identification, because you should be able, the receiving team should be able to identify the patient by that, the patient demographics and room number, which you rightly mentioned. So what I heard you say was that the patient is a 72-year-old Mr. Jones. So you have identified the patient by name and age, and you went ahead to mention the patient's room number. So that's a 3-point identification. You also...
Wait, let me ask, why do you need all these identifiers?
Well, so it will interest you to know that there may be 2 Mr. Jones even on your patient list. And interestingly, they may have the same age.
That's very true.
Yeah, but they will never be in the same room.
Definitely.
Not at least at Piedmont. Yeah. So you need these identifiers. We say at least 2. It's okay. You obviously don't need the MRN number. So Mr. Jones, 72-year-old male who is in room 312 or whichever room. You mentioned that he's a full code. Why is that important?
It's very, very important in the setting of resuscitation. So, for example, if this patient stops breathing, right, you wouldn't want to. You need to know that he's going to go through the whole resuscitation process. Should he have been DNI, DNR, he quotes, you are not supposed to touch it.
So our audience are not sure what DNI is.
Also, DNI means that you do not intubate, do not resuscitate. So it's important to know these stages of the patient so that you know exactly what to do in the setting of an emergency.
So a full code is a patient. It means the patient wishes that when I have a cardiac arrest, I want you to do a chest compression. I want you to intubate me. Is that correct?
That's very correct.
Okay.
Yeah.
And do not resuscitate, do not intubate means no chest compression.
No intubation.
Okay. All right. So you want to know the patient wishes, because if Mr. Jones, for instance, become hemodynamically unstable, go into cardiac arrest, and he's a DNI, DNR, we know that we cannot go ahead and perform any resuscitative measures. Agreed. Okay. All right. Then you mentioned that he's a watcher. Is that what you said?
Yeah, he's a watcher. So
what does a watcher mean?
A watcher is someone who is, say, stable at one point but can easily deteriorate at any given time.
Okay.
So
we are watchful of.
Very watchful of him. He's someone you're supposed to keep an eye on. There are other severity scales when it comes to wordings like that. We have people who are stable and people who are unstable.
Okay. So
with a stable patient, he doesn't need as much attention. With a watcher, their clinical condition can just switch at any time. So there are people that you have to pay some attention to, and unstable patients as well, and unstable.
They will have been in ICU, and we all know that they are unstable. I think the ones that scares me most is the watchers.
Yeah.
You never know what to expect. Okay.
I agree with you.
All right. So that's about the I in the IPASS. The IPASS is actually IPASS. So I mentioned that it's represent the illness severity which you alluded to as a watcher. And then I also mentioned that I, my own twist being the identification. Now we go to the P. What does the P stands for? I think it stands for patient summary, and you did a good job by summarizing Mr. Jones' situation. You mentioned why he was in the hospital. You mentioned what you have done for him, which are relevant things you've done for him. So he came with GI bleed because he was having melena stool, and then you have hemotransfusion, right?
Yeah.
With 2 units. Did GI plan anything?
Yeah, GI planned to scoop him, so we are kept him NPO.
All right.
Yeah.
Okay. So those are very, concise reports of what Mr. Jones came with and what you have done for him. So that's basically the patient summary. It's not the full history of the patient. We don't care what the patient ate yesterday before coming, right?
Of course, it's unnecessary.
Yeah, okay.
And sign-outs are supposed to be very short, precise, and concise.
Yeah, because trust me, that is the point that I am leaving work and you are coming in. So I'm so tired and I don't have time to say everything in the history. You are just beginning and you don't want to be overwhelmed. I'm not the only one signing out to you. So it has to be summarized as much as possible. Now the A in the IPASS, so we've tackled the I, the P. The A is actually the action list. And in your sign out, you told me exactly what you need me to do. You want me to check on the HB at a specific time.
Yes.
And if it is below a certain value, you told me exactly what I need to do.
Yeah.
And you gave me conditions. Should he become hemodynamically unstable and all the stuff, which we'll tackle. But the A is the action list or the to-do list. Do this at this time when you have seen this. Okay. So actionable steps without ambiguity speaks for the A. One thing I need to point out is your goal for hemotransfusion was different. It was 8 and not 7. Can you tell me?
Yeah, so for patients who have a history of coronary artery disease, the transfusion threshold is higher. So it's 8, and then with other normal patient populations, it's about 7.
I won't ask you to quote any trial. not today. Yeah. So we talk about the first S, right? The first S is the summary, awareness, and contingency planning. So in the case of Mr. Jones, you mentioned that if he becomes unstable, what should I do? I should transfuse, call GI. So, the action list was that check the HB at this time and do this. But you went ahead and gave a contingency plan or a summary awareness that if he becomes hemodynamically unstable, I should do certain things. So that too is very important because you may be given a sign out and a to-do list, but other things can happen based on the patient clinical context, and sometimes it's important to anticipate things that can happen, and that has been captured in this component of the summary awareness. And then the final part is the synthesis by the receiver. It could be that I'm not listening to you when you were signing out, so it's very important that I, close the loop of communication by either asking you questions, clarifying questions, or summarizing back what you sign out to me. So if I get you right, I don't need to talk about the identification and all those stuff because I'll have written it down. But his goal HB is 8.0, right? And you said GI is already on board.
Correct.
So if he becomes unstable, I could contact GI.
Yes. All
right. Okay. So that's it. Very concise, very brief. It's not packed with superfluous information. Beku hits the nail right on the head by giving me a very concise sign out, and I think it tackles all the essential components if you use the IPASS framework. And this is something that will come out very handy when you start residency. You will not even think twice about it. It will just flow. So, I think what we'll do is we'll pick a number of clinical scenarios and how to sign them out. GI bleed is one of the commonest ones we sign out because we tend to monitor the hemoglobin and the hematocrit very often, and one needs to follow up on that. But there are other common sign-outs like troponin trains and all those stuff that we can demonstrate for our listeners to have a feel of it before they start residency. Because trust me, if I have such an experience and know how sign-out goes, I'll not be nervous during my first sign-outs.
Oh, well, yes. I remember when I had to give my first sign-out.
You think it's something so we actually make a big deal out of it when we start residency, but with time, you can actually close your eyes and be signing out. So it gets better, trust me.
It really does.
Yeah, so Until we see you in the next video, keep watching and subscribe to our channel if you like our content. And until then, have a good bye.